My name is Dr. Kirti Bhushan. I am a consultant surgical oncologist in the Department of Surgical Oncology at SL Raheja Fortis Hospital. So today we'll be discussing about recent advances in the surgical management of colorectal cancers. Colorectal cancer is third most commonest cancer in males worldwide and second most commonest cancer in females worldwide. As far as India is concerned, colorectal cancer is sixth and seventh in terms of incidence and mortality, respectively, in males and females. Over the last 10 to 15 years, a number of advances has been made in understanding the biological behavior of the tumor, the pathology of the tumor, its pathogenesis, which has led to a revolution in managing the colorectal cancers. There has been advances in the field of surgery, in the field of radiation, and in the field of medical oncology that has led to overall improved survival in patients suffering from colorectal cancers. As far as etiology is concerned, uh, people who have first or second degree relatives who are suffering from colorectal cancer or any other malignancy, they are more prone to have a colorectal cancer as compared to the general population. Uh, People with the familial history of multiple polyps in colon and rectum, they are at more risk. People with the history of any inflammatory disease after the age of 50, they are more risk of having a colorectal cancers. People with uh, who have westernized dietary lifestyle, a sedentary lifestyle, alcohol and smoking, these all contribute in the etiology of colorectal cancers. If we see the behavior of the tumor, the colorectal cancer doesn't develop overnight. It's a process in which a normal epithelium in the colon or rectum, it gradually changes itself, its character from normal to abnormality, it becomes to adenoma, and then ultimately it becomes a carcinoma. So it's a 10 to 15-year period by which these genetic events occur in an intestinal epithelium, and ultimately it becomes a cancer. So by um, by knowing its etiology and its pathological behavior, we have come to know that if we do a dietary and lifestyle modification, we may be able to prevent those changes if we are able to prevent those changes at the earlier onset, we may help ourselves prevent to develop a colorectal cancer. So prevention is better than cure. So we must remember a formula of LMNOP. L means less of fat and more of fiber diet. M means more of fruits and vegetables. N means no to smoking and alcohol. O means organizing yourself. And P means physical activity. So prevention is better than cure. Now, as far as the diagnosis of the colorectal cancer goes, there is a standard staging protocol. Any patient having a suspicion of colorectal cancer has to undergo a colonoscopy and biopsy to prove that the person is having cancer or not. Second thing is contrast enhanced CT scan of abdomen and pelvis plus chest X-ray normal and uh, blood test which includes a complete hemogram, liver function test, kidney function test, and tumor antigen CEA. This is the standard staging protocol, baseline things. Now, we don't require MRI or PET scan at the onset. MRI and PET scan are the investigations which are optional. Now, MRI we use only when especially in mid or low rectal cancers where we have a doubt whether disease is localized or a slightly locally advanced, where it can change a plan of treatment. We may be giving a neoadjuvant chemotherapy or radiation first, then followed by surgery, or if it is localized, then you go for surgery first, followed by chemotherapy and radiation. So MRI pelvis is for that. PET scan is only done when CT scan or chest X-ray is showing any suspicious of metastasis in these sort of patients. So otherwise, if CT scan and chest X-ray is not showing any evidence of disease elsewhere and there's a localized disease confined to the bowel only, then at the initial stage, PET scan is not required. PET scan is only for optional. Now, these patients can have various symptoms. They can present with bleeding per rectum. There can be abnormality of bowel habits. Now, patient, if for a prolonged, they can have loss of weight, loss of appetite. They can have these all constitutional symptoms. Right side colon cancer, sometimes they keep on bleeding, and the patient can have severe anemia. They can present with decrease in the hemoglobin and severe breathlessness. They can feel at home. Now, patients, if they are metastasis, there can be if it has spread to the liver, there it can present with a jaundice. If it has spread to the lungs, so it can present with cough, hemoptysis. Patients can a clinician can feel an intra-abdominal mass palpable, or there can be supraclavicular nodes above our collarbone. They can be palpable. So there are various presentations with which the patient can present. Sometimes the disease is so advanced that patient can present with severe bleeding. Patient can present with perforation of the intestine because of the obstruction. So these are various presentations with which patient can present. So if we have to see, there's a lot of things that have happened in the surgical management of colorectal cancers. There have been we have redefined the principles of managing colorectal cancers, and we have uh, added technology to it. There has been addition of staplers as well as hemostatic devices like harmonics and all, with which surgery can be bloodless, and with staplers we can do anastomosis where the leak rate is very minimal. Now we have redefined the techniques also. We The complete mesocolic excision in colon cancer and total mesorectal excision in rectal cancers have helped us in doing a surgery where you go through a avascular planes, you resect the disease properly in its entirety, you get a good margin, and at the same time you harvest more and more lymph nodes, because we must understand our R0 resection or complete curative resection means that you have to take a good margin at the primary tumor level, and at the same time you have to do a good lymphadenectomy as well. Now, this is an era where we have come from mutilating surgeries to sphincter saving surgeries. We have facilities of staplers where we can preserve the lower rectum. We have facilities of frozen section where during intraoperation you can check whether your distal margin is involved or not, and thereby you can be sure that whatever rectum you have preserved is free of cancer. Now, there has been various modalities which have added, for example, neoadjuvant chemoradiation in case of low rectal cancers, which are bulky, which are locally advanced, where a person wants to preserve his sphincter. Now, in all these situations, neoadjuvant chemotherapy is given first, and then it is followed by the surgery. So, sphincter saving surgery has become uh, the trend of today, because we must understand that patients having a normal sphincter where from which he defecates, patient having no colostomies, they have a good quality of life as compared to the patients who have a permanent stoma or even a temporary stoma for some period of time for all these rectal cancers. The laparoscopy has also come in a big way in managing as well as robotics. But caution is here, because our Indian patients, they are mostly in third stage, they are mostly locally advanced, and especially for rectal cancers, mid and lower rectal cancers, the rate of positivity has been shown more in locally advanced cases where we venture laparoscopy or robotic. So the idea is that people should be experienced enough to perform these procedures. The patient selection should be good. The patient has to be in early stage. Then the results plus experience of the surgeon doing the surgery, it adds to the benefit of the patient, and it makes it equivalent to the open surgery. HIPEC in the management of colorectal cancers has also come in a big way. We have seen that patients who recur or who have a limited peritoneal disease, we do a complete cytoreductive surgery, then followed by intraperitoneal chemotherapy given at high temperature. So it has also added benefit in selected number of patients. Now our SL Raheja Hospital is well equipped. It has a good center for managing colorectal cancer. We have a good infrastructure where we do all the staging workup. Patient doesn't have to go elsewhere in the to other hospitals for other investigations. So all the investigations from A to Z in the staging of the tumor can be done. We have a team of good pathologists led by Anita Borges, who always gives us a correct diagnosis, and we have a good team of anesthetics and surgeons here. We manage colorectal cancers. We are doing laparoscopic surgeries as well, and we are doing more and more sphincter saving surgeries because we have the technique. We follow the technique of complete mesocolic excision. We follow the technique of total mesorectal excision in managing rectal cancers. Thereby, it has helped us in doing a good surgery, good R0 resection, and we are avoiding colostomies in most of the patients, and most of our patients are having decrease in local recurrences, and they have improved survival and good post-operative results in terms of early recovery and going home in shorter period of time. We have been also doing at SL Raheja the techniques of intraperitoneal chemotherapy, HIPEC, which is for colorectal cancer. Apart from that, if there is a metastasis in the liver and liver needs to be managed, we have facility of doing an open surgery of hepatectomies. Apart from that, we can do transarterial chemoembolization, the facility for radiofrequency embolization is ablation. Radiofrequency ablation is also present in SL Raheja Hospital, and more and more we are using current drugs in the management of metastatic colorectal cancers. All the patients with metastatic colorectal cancers, if they are unobstructed, if they don't have any bleeding, they should undergo a chemotherapy, and new generation of chemotherapy drugs are available which our medical oncologist prescribe to them. We have a good colostomy care unit here which takes care of the patients in managing their stomas. They can visit to their home as well, so that they cannot come to the hospital again and again. Now in this COVID era, I must emphasize that there is no threat in getting operated whosoever is suffering from colorectal cancers, because we have operated in this COVID period and all the patients are absolutely fine. The reason is that we have been following a strict protocol at SL Raheja Hospital. There's complete segregation of COVID and non-COVID patients. The non-COVID patients are properly evaluated and properly treated. They are getting a separate sisters, separate ICU care, and separate paramedics to look after them. And with all the facilities to the attendants and relatives also who are with them in so we at SL Raheja Hospital are providing a complete package in the management of colorectal cancers. Apart from that, in these difficult times, we know that people are suffering, people are having economic crisis. We are we are performing surgeries at concessional rates at SL Raheja Hospital. Plus, this hospital is also well equipped in doing some palliative work as far as colorectal cancers. Those patients who are terminally ill are given care. We can do a endoscopic stenting in a terminally ill patient who is obstructed. So, a lot of other palliative pain management also can be done here. So, right from early stage to even late stage or advanced stage, there is a proper infrastructure, proper manpower, and proper consultants who are qualified in doing this fantastic job we have available here. So I would emphasize that we all must have a good dietary and lifestyle habits, so that we must prevent this cancer from occurring. And if it occurs, if there are symptoms which I have already mentioned, if these symptoms persist for a long period of time, if they don't subside for a period of 2 3 4 months, it's always better to visit a hospital and get yourself checked and get yourself treated. So in this COVID era, I will always tell to everybody, stay safe and stay well. Thank you very much. ठीक है भैया? Yes.